And I'll try and move over so everyone can see me. So my name is Okorie. I'm actually pediatric pulmonologist and actually sleep trained, but so the sleep train is actually pediatric and adult, so I'll focus it more on adults, right, for you guys. And as I was saying, I actually am, and I'm at Stanford, so just down the street. And the way I even got connected with this is I was giving a talk at our CF Education Day in March. February, time's flying. And then I got approached and she said, hey, you want to come talk here? And I was like, sure, why not? So thanks for having me. Thanks for lunch.
Thanks for coming.
Of course, thanks for discussion on Marvel. We could talk more afterwards. I'm happy to give my opinion. I have many opinions on Marvel. I have two brothers, comic books. I've watched all 22 movies.
Oh my God.
Yeah, anyway, yeah. We'll do sleep first, and then we'll talk about more. So I have no disclosures or conflicts of interest. So my goals, I was trying to put in some kind of with the theme. I didn't know about the Game of Thrones theme. Wouldn't have made a difference because I don't know anything about Game of Thrones. But at least for the wolf, I was trying to, this is just a sleeping pack. So my goal is for you guys just to increase your knowledge about sleep medicine and sleep in general, and just really empower you to bring your sleep concerns to your doctors and your providers. And just really, the more I learn about sleep, the more I realize how important it is to help us thrive in just about everything. So I think it's when I always tell the story, when I was in college, I actually had the sign above my desk that said, you can sleep when you're dead. And it was just, I was like, all-nighters, that's, hardcore. And looking back, I'm like, that was the dumbest possible way to learn, is to not value sleep. So I think the more I learn about it, I'm like, it's actually really important. So, but I also actually hope to learn from you guys. So, because I'm going to go over kind of what the literature knows and what the medical community knows about sleep, specifically with people with cystic fibrosis, but you guys are living it, so please tell me if you're like, oh, actually, this is something else to think about, or so. We'll make this informal, please interrupt as we go. So a little bit talking, understanding why sleep is important, discuss some specific factors relevant to patients with CF, discuss the available stats that we have, review some common sleep disorders, and there's some possible treatments and strategies. And for those of you who are at the CF Education Day, some of this will be similar. I expand a little bit on a few things, so I'm sorry they're going to hear a lot of these things again. But so what is sleep? We used to think it was just the absence of wakefulness. We used to think it was just nothing was happening. We were just not awake. But does anyone know who this gentleman is in the Dr. Dement? So he actually is here at Stanford. He's like 95 now. So he actually kind of discovered sleep, for lack of a better phrase. It's kind of amazing. So he discovered... Yeah, so he's like in his 90s, but he's still kicking. So he discovered dream sleep, kind of really discovered like why we sleep. So he was one of the pioneers. It's just kind of cool that we're in the same area where, this guy the first sleep center actually ever in the country is at Redwood City. So we now know it's an active process with several phases and stages. It's regulated by several neurobiological processes. It's super complicated, but briefly, this is a normal sleep architecture. So what you'd expect is you kind of, this is wake. This is dream sleep. These are the different stages of sleep. This is kind of like super shallow sleep. This is actually deep sleep. A lot of people think of dream sleep as deep sleep. It's not quite true. Dream sleep is actually your brain is, I think we've talked about animals here. So those of you who have dogs or cats, thank you. Those of you who have dogs or cats, you probably have seen your fur baby kind of go like while they're sleeping. So they're dreaming, and so they're not like chasing that cat all around the house. Their muscles are relatively paralyzed. So that's actually why it's like their brain's actually super active, but their body is inactive. And then so they're actually really easy to wake up in that state. But then if you're in slow wave sleep, for those of you who might have kids, and you actually see like kids who have like that like really even, easy, relaxed breathing, that's actually slow wave sleep. That's actually where you could practically take someone, I joke, like take a 7-year-old, sling them across your shoulder, walk them upstairs, and they don't wake up. Like that's actually deep sleep. And then light sleep is kind of in between. So it's actually, you'll notice it's actually normal for us to wake up a couple times in the middle of the night. Usually it's short enough that you don't remember it. You might do a quick wake up, turn around, and then you fall right back asleep. So waking up in the middle of the night is not in and of itself abnormal. Other things that are kind of important to know is that dream sleep, it becomes longer as you move through the night. So typically between people always say, oh, I have more dreams 2, 3 in the morning, between 2 to 5. That's actually when you see more dream sleep. So just there's this kind of natural architecture we typically see. So, oh yes,
So you mentioned waking up in the middle of the night is like totally common. And I know like around 4 I tend to like get up, drink water, go pee, and then go back to bed and sleep more. Is it more likely to happen like later in your sleepiness or earlier, or is it just later that you're more likely to remember it?
so it kind of depends on why you're waking up. So I think usually if you're waking up to the point where you feel like you have a full bladder, and or that you feel like you're thirsty or getting up, it could be that your breathing is not as effective because during probably 4 in the morning is when you have more dream sleep. So it could be that with your muscles more relaxed, your brain is actually sensing, oh, we're not breathing that effectively. I need you to wake up a little bit. So then you kind of just, oh, I'm awake. Let me go to the bathroom. So that actually is a very common thing that people experience.
Okay, interesting.
Yeah, so it's supposed to happen throughout the night, like maybe 3-4 times throughout, not really in one spot. But people who have it more in the early morning, it could be a breathing issue. Not necessarily a dangerous breathing issue, but could be a breathing issue.
Right. Well, I also like
I was gonna say, then there's the other aspects of too. So it could be like through the night you've been laying there, you've been collecting more phlegm. So that's also another factor too. Good point. Which actually is a perfect segue to here. So like why sleep is a vulnerable time. So this is where your minute ventilation is decreased. So this is how much air gas is exchanged. Your lung volume per breath is decreased, and your upper air resistance increases for some of the issues you talked about. And then just like I've been saying with REM sleep, that's when a lot of this is a little bit more pronounced. So we talked a little bit about sleep. It's supposed to be restorative. It helps build your muscle and bone. It activates your immune system. It consolidates your learning and your memories. That's why I laughed that like when I was in undergrad, actually all-nighters was the worst thing to do before a test. Really, I should have studied, slept, and then took the test. So because it actually helps you transition your short-term memories into more long-term memories. Just why, like, if you find that you don't sleep as well, you probably find that you're, like, forgetting things more. You're like, what's that thing called? So poor sleep causes problems. It causes low mood, poor learning, decreased immune function, heart disease, hypertension, diabetes, depression, anxiety. And unfortunately, it's like the whole gamut. It can make all these things worse if you're already struggling with them. And then even newer studies have associated poor sleep with increased depression, suicide risk. So I think it's something that we need to really think of as an emergency if you're really having poor sleep. So for sleep duration times, so people always ask, well, how long am I supposed to sleep? So kids, like babies, they're just sleeping all the time. So, that's just, they really just do sleep all the time. And then as, I don't know, if somebody has like grandparents who only sleep like 5-6 hours a night, that's usually for the older adult. But for young adult, so generally you'd say 7 to 9 hours. Some people need 10. There are some people who only need 6. I will say they're rare. The kind of literature shows that really no one does well on less than 6 on average. You might hang in there for a few days, but then if you have to like recover on the weekends, that's not the same. So I always just like tell people, try and get at least 7 to 9 hours of sleep is ideal. So what keeps most people from getting enough sleep? Right, and I show this. I did this. Like this is me last night. So I mean, like I'm not no judging. The phone, your stress, work demands, family social demands, and just general medical issues that can keep you from sleeping. But I will say the phone is really becoming, especially amongst my lovely teenagers, and is really becoming a little bit of an issue. And then you add cystic fibrosis on top of it. You have cough, phlegm, musculoskeletal pain, frequent stooling, heartburn, discomfort, overnight feeds, right? You're trying to sleep. I mean, it's not really what your body should be wanting to do, but we're filling it up with nutrition as you're trying to sleep. Maybe needing some treatments during the night or different medications you're taking can affect your sleep. So, in the studies that we've seen, studies show that 50% of patients with CF report some sort of disrupted sleep. So unfortunately, it's very common. And this increases with the degree of lung disease. So, or if you're awaiting transplant, which correlates with the severity of lung disease. So children and teenagers with CF are affected by insomnia and sleep disturbances at really high numbers. And then more than 80% of children with CF actually report coughing through the night compared to like less than 5% in the general population. So it's definitely a big issue. Pain, chronic pain is reported in many patients with cystic fibrosis, and many just report that they just kind of get through it and self-manage it. And this might be some of your stories too. So I always tell people it's great to take ownership over your own care and feel like, you know what, I'm going to try to self-manage it myself, but I think it's important to let your CF team know and see if they can kind of help you to deal with pain, and that's not something you necessarily have to deal with on your own. So if we're thinking of how do we objectively measure sleep quality, so I think we can kind of like get a sense of like, I think I sleep okay, I don't know, I'm not really sure. So we actually can do something called a sleep study. Has anyone ever had a sleep study? Okay, how was the experience for you? I'm just kind of curious.
It was horrible. Like, those sit on your head, and then they're like, go to sleep, and, you know, they know they're watching you, and go to sleep, and then they wake you up really early, and then they send you home with this stuff on your scalp, and then you go back to bed, because then you're actually sleeping in your room.
Yeah. Yeah. So it's true. It's funny because I actually find the older, it's so interesting because my training was in pediatric and in adult medicine. I find the older you are, the harder it is, and I mean like older meaning above like 10, the harder it is to actually sleep in sleep studies. It's funny because a lot of people say there's no way a toddler's going to sleep. Kids are like, whatever. You go like, it's a game. And they're like, all right. And they fall asleep. It's great. But then like once kids are like 10, 11, 12, they like, because you're just so much more aware, like there's stuff on me. People are watching me. What are they watching me do? What if I do weird things in my sleep? So it can be hard for people to sleep during sleep studies. But I will say the vast majority, like 90% of people actually do get some good data. So if your doctor recommends a sleep study, don't be totally scared off by that story. But
Because once I got my CPAP, I slept much better.
oh, okay, great. Oh, good. I might hit you again a little bit later with some to get more of your experience. So just to say that sleep architecture, I said generally, CF doesn't mess with your sleep architecture unless, of course, you're having things that interrupt you and wake you up. But it's your brain still getting into the same stages, that there's no issue there. If you are having a pulmonary exacerbation, you might have less dream sleep and more wakefulness. If that makes it's just you're just more susceptible to wake up if you're not breathing as effectively. Other ways you can actually measure something called an actigraphy test. Has anyone had this study? So this is where, so a lot of people will like wear like a Fitbit or something like that and say like, oh, by my Fitbit, this is like how I'm sleeping. And Fitbit's okay. It really is just measuring your sleep by your movement. So if you think about it, if you like just lay still and you're wide awake with like insomnia, it thinks you're asleep. So it's not the most effective. I mean, like you're really trying to kind of distinguish out, but actigraphy is similar, but the accelerometer in it is a little bit more advanced. So this can actually help determine your sleep-wake pattern. So if you're kind of really trying to figure out what's going on with your sleep and your wake, this is another study. And this has been done looking at patients with CF, and that's how we know that they have more sleep disturbance objectively. We're talking about sleep study, and in sleep study you can measure the reason why you have all that junk put on you is to measure your breathing, your heart rate, your oxygen, your carbon dioxide, your limb movements, everything. So I'm sure you remember even you have something in your nose, measure flow in and out of your nose. Yeah.
Sleep architecture?
Oh, sorry. Sleep architecture just means, that's a great question. Remember that it just means the normal stages of sleep in the normal order that you go through. So sorry, yeah, it's just a fancy word that I don't know why that's just what they say, but essentially means we expect you to go through shallow sleep, less shallow sleep, deep sleep, dream sleep. It's just that normal movement we see. Yeah. Oh, and I can repeat the question too. Oh, okay. Go for it.
Are there any studies comparing patients with CF who use sleep aids versus not, like anti-anxiety drugs or anything as an aid versus not, and the differences?
That's a great question. So I didn't find a lot in literature that compared specifically patients with CF who are taking sleep aids versus those who are not. There are a lot of studies in literature about people taking sleep aids versus people who are not. So it depends on the sleep aids, and I'll go into a few of those. Like what they actually do. There's some sleep aids that I think a lot of people think are great go-tos, but I'll kind of talk to you about why not. And there's like things that are ubiquitous, you can buy anywhere, like at Target, like melatonin and whatnot. But we'll if I don't answer your question a little bit more, please remind me. Okay. Yes.
I was curious about, well, it's slightly off topic, but about pain. Like, for example, Georgia experiences a lot of pain at night. In Ohio, medical marijuana is becoming a big thing. Or is trying to become a big thing. And what's your opinion on that? Is marijuana as a pain regulator?
So, just the first part was about, marijuana for pain. Honestly, I think people are still, because in California too, marijuana is legalized. I think people are just starting to research it, to be blunt. So I think if you go to some dispensaries, they'll tell you that marijuana, this one does pain, and this one helps you focus, and this one helps you be happy. But do we have the data? I don't know. We're still getting it. And actually, it's funny because we have an annual American Thoracic Society meeting, and I'm actually on their sleep education committee, or how we determine which topics. And that's actually one of the topics we want to talk about because there's so little literature out there. So we're going to try to see if we can find someone who has a lot of experience and is more senior can kind of help us. So I don't have a great answer for that, unfortunately. But I do think there's actually a recent article I just saw this morning on my email about marijuana in place of opioids. I haven't read it yet, but it just came out. So we'll see if there's anything new. But I think people are actively looking at it. Because I think we already know the benefits in terms of appetite and seizures, and I think we know some of the things that marijuana has benefits, but I think we're still figuring out with pain. And then I think it's like for adults versus for kids, so like I'm on the pediatric side, so I think the one we have found on the ped side is that it actually changes your brain chemistry and how it develops. So I think generally for kids, for young people who are still developing their brains, we say, let's try to hold off on marijuana for now until we know more. Actually, changes how your white matter versus gray matter develops. It's actually kind of interesting. But in adults, it's a different issue. So sorry I don't have a better answer, but it's a great. That is the question that everyone wants to know now. So a couple things we looked at the sleep study. So we looked for nocturnal hypercapnia. So this is retention of carbon dioxide, which I'm sorry, some of you guys might already know all this stuff. But so this is patients with CF have increased risk due to parenchymal lung disease. So if your tissue gets a little bit more thick, it's harder to exchange carbon dioxide and oxygen. So that's one of the things that we look for. The note is this is actually typically seen at night. You'll have issues with this before you'll actually have issues during the daytime. So if you tend to wake up with a headache in the morning, this could be a sign that you're actually retaining carbon dioxide. So this is where a sleep study could be helpful to know. Even if you're not retaining it during the day, you could be retaining it at night. And then the other thing, nocturnal hypoxemia, which is low oxygen. So again, for the same reason. So the same thing where, again, you might have some low oxygen levels when you're sleeping before it shows up during the daytime. So again, if you feel like you wake up with a headache or you feel like your sleep is really disrupted, it might be worth getting a sleep study or an oximetry study. And then, consensus guidelines, just is like when should you use oxygen at night? We generally say for adults, if your saturation is less than 90% for greater than 10% of your total sleep time, or your minimum oxygen level stays like below 85% during the study, that you might benefit from some oxygen when you sleep. So sleep apnea, which we
Sorry, what was the last point? Oxygen can be...
I'm sorry. Yeah, so... the reason why a sleep study is helpful is because, again, we're looking at carbon dioxide and oxygen, we're looking at both of those things and how they interplay together. If you tend to be someone who retains carbon dioxide, so if you tend to retain carbon dioxide, it actually having a slightly lower oxygen level tends to be like your one of the prime drivers to help you breathe through the night. Meaning your receptors in your brain say, okay, well, hey, this carbon dioxide is always going to be high, so let's focus more on the oxygen level to determine when we take our breath in and out. So then if you just, without fixing the carbon dioxide issue, if you just give oxygen on top of it, you're actually taking away that really sensitive drive to breathe. And so sometimes it actually can make you worse if you just do oxygen without looking at the carbon dioxide as well.
How do you know that that's happening with carbon dioxide?
Great question. So sleep study or a blood gas? Yeah, or your electrolytes can sometimes just tell you. So just checking, sometimes your electrolytes can actually kind of also give you a hint. So if you tend to have a high carbon dioxide, your body sees it as acid. And so if you kind of always have acid, your kidneys will say, oh man, you know what, we're always acidic. I don't like that. So let's actually retain something called bicarbonate, which is usually dumped by your kidneys, and actually that's to balance out the pH. So if you have a high level of bicarbonate, that might be a sign of like, oh, he might be retaining carbon dioxide chronically, and the body's trying to compensate for that. Wow. So there's like kind of 3 different ways you can do it. You can do sleep study, you can do blood gas, or you can just do your normal electrolytes. You were saying something before I interrupted.
Yeah, how do you address high carbon dioxide?
great question. So, and so I'm going to talk about a few things. So there's, one is you just help, like let's say you're having an exacerbation. So you might have higher carbon dioxide during an exacerbation, so treating that. Another way is a machine, we're going to go to a little bit like called bi-level, which actually helps with gas exchange. So it's really just helping with the breathing. But I will get to exactly what that machine is. Yeah.
We know that the bicarbonate channel in the cells is disrupted as well as the sodium chloride channels. Having CF, would your bicarbonate necessarily go up in your blood levels?
We do still see it go up, but you're right. You're saying it's not always as sensitive, that you can still have an issue without that bicarbonate raised. You're right. Yeah. Great questions. Thank you, guys. Sorry for skipping over that important point at the bottom. Thanks for calling me out and bringing me back. So OSA, this is a common thing that something like 50% of patients over 50, or not patients, people over 50, are believed to have obstructive sleep apnea. So the symptoms, this is the snoring, the gasping for air. Essentially what's happening is that you're not breathing very well. Your brain can sense it. It'll do a couple things. One, it will tell your heart to beat faster. So it's like, hey, let's move more oxygen through the blood. So you might feel like your heart beats faster. It'll also say, hey, I need you to breathe deeper and use more muscles. So then if you watch someone has sleep apnea, you see that they're always kind of like working. So, and then eventually your brain might be like, you know what, you're not doing enough. You need to just wake up. So that's the gasping awake, right, that you may hear. And so if you think about that, it's almost like somebody elbowing you awake every few minutes. And you can imagine how rested you feel the next morning. So that's why sleep apnea, that's why you feel so tired when you have sleep apnea. And then all the things that come with it, poor concentration, restless sleep, low mood. Sleepwalking actually was like you kind of partially wake up, but not all the way. So you can have more sleepwalking. And then I say insomnia, because also if you think about it, if you're revved up, like your heart's beating faster, your lungs are breathing deeper, and then you wake up in that state, it's like you've been running. So you like wake up feeling fully awake. So that's why a lot of people say when they wake up in the middle of the night, they have a hard time going back to sleep. So going back to like kind of what we were talking about earlier, if you feel like that's happening around like 2 to 5 a.m. and people have a hard time falling back to sleep, I always wonder like, gosh, I wonder if you're having some sleep apnea that's not being detected. So patients with CF have increased risk for sinonasal disease, so just like nasal polyps, inflamed airways, that can increase nasal obstructions, so that can increase your risk for sleep apnea. Children actually tend to have more, children with CF tend to have more sleep apnea than adults because they have the tonsils and the adenoids, these big tissues in the back of your throat and in your nose that just create a blockage. And then I always say promoting effective nasal breathing instead of mouth breathing is actually really important for kids. So if you guys have any kids who tend to kind of breathe through their mouth, that's actually something to address because if you tend to, breathe through your mouth, I use poor Napoleon Dynamite because I feel like he's a great example of what happens. So this is just showing two different pathways here. So if you're able to keep your mouth closed, your tongue actually is supposed to rest in your palate, so in the roof of your mouth, and then it's actually supposed to help actually expand your palate. So you're thinking about your tongue is a muscle, and as your child growing, it actually helps kind of with your facial development. But if you can't, your nose is blocked, you're not going to breathe through your nose, you're going to open your mouth. So if you open your mouth, your tongue tends to sit at the bottom of your mouth, so it's not sitting in the palate like it should. And then you actually tend to develop this long, narrow face. And then with that, a long, narrow airway. So I laugh, like in my pediatric sleep practice, I feel like people think I have stock in Flonase because I'm like always saying like, we gotta get you breathing through your nose because it's so important.
So if are you saying that the way that you breathe can affect the structure of your face?
Yeah. It's crazy. And granted, this is for kids. So once, everything's solidified and bones are done, your face is your face.
Yeah.
But like think of it this way. So did anyone have braces growing up? Right. So why do braces work? They're like gentle pressure, right? And it causes your teeth, your bones to move. So when you're still growing, it's like even gentle, like, or if you've seen a baby who like always lies down, they have that flat head. So it's just when you're growing, you're very susceptible to even gentle pressure. So if you think about it, you're always like this, you're just kind of, that's what you're telling your body to grow. You're like, no, I want you to grow long and narrow and open. And so it's like, all right, it does.
Yeah.
I know, it's crazy.
Never look at people with pointy chins the same.
I will say it's It's true. It's crazy. Like I'm like a huge Foo Fighters fan. I always look at Dave Grohl and I'm like, oh, Dave, I hope you have a CPAP. Like every time I look at him. So if you just look at his face, you're like, ah. So the man who, see, now when you look at him, you're gonna be like, oh yeah. So the gentleman who actually kind of described this phenomenon was actually also at Stanford and started the sleep center with Dr. Demet. His name was Dr. Guilleminault, so it's very interesting. And so he sadly recently passed away, but I got to train with him, and he would just walk up to people. He was 80. He would just be like, oh, your face is all wrong, and it was just. And we'd always be like, you can't say that.
Look up later and show people.
You can't. I mean, no, I did not create this. This is something. Yeah, you can. That's the site. I can actually give you guys. So these slides, I'm putting the credit. Like these, I don't own the copyright to any of these pictures, but feel free. I'm happy to give it to you guys so you can have this for your records.
My significant other grew up, like his entire life, he couldn't breathe through his nose.
Oh,
And when I met him, I'm like, well, let's do something about that. You just want to never breathe through your nose your whole life. You can't smell. So he went and he got surgery, and now he can actually breathe through his nose. But now I just kind of wonder, I want to show him this because he'll be like, oh my God. His parents did nothing either. They didn't, they're like,
well, they didn't know probably. Yeah, they probably
just your lot, do something. He's like 44 and couldn't breathe through his nose ever.
It's great you can breathe through your nose now, but there's
But he still can't smell.
No hope for your face.
I know, apparently.
You know what? You can still be a very good-looking person with a long, narrow face. Yeah. So the treatment, let's say if you have a septal deviation or a broken nose or something, then the treatment is surgery, right? If that in place of that, the most common thing is just allergies, that people just haven't treated. So I always say Flonase, which is an intranasal steroid, so you spray it in each nostril, and it actually reduces the inflammation. There's things called turbinates, which are kind of these balls on the sides of your nose. And so when they swell, that also makes it harder for you to breathe. Or your adenoids, which are way in the back of your nose. You actually can't see them, but they're kind of here at this level. Those actually swell with allergies. So this is a really effective way. And it doesn't have to be Flonase. It could be generic Flonase. It could be Nasacort, anything. But just the idea of an intranasal steroid spray or even an antihistamine spray directly to your nose is pretty effective. If you want to avoid that, saline rinse. I also am a huge fan of neti pots and those things, because if you think about it, it's a drug-free way to just help clear the nose. Key things are that the distilled water, boil the water, make sure it's clean, and even with the bottle, kind of keep it clean too, let it dry completely. There's people, you can also buy porcelain neti pots, which you can actually then run through the dishwasher, through the sani rinse, just to keep things clean as well. Key, do not try to use just plain water. It will burn. I wanted to try once. I'm like, what would happen if I use, oh gosh. So don't do it. I tried it for you and it burns. So your body wants saline. It needs a little bit of salt. And then if you get one of these Neilmed or these things you buy in the store, it's comes in a salt pack. It's pretty easy to do. You just put it in there. Another treatment. So those of you maybe had braces. I don't know if anyone. And I'll say. So I actually was a tongue thruster. So this was me growing up. So I had a total open bite. I could stick my finger through, if I had my teeth completely closed, because my tongue was always pushing against, caused me to have a lisp and all this stuff. Interestingly, actually, and now I'm sharing too much about me, but it's because I have a tongue tie that I never got treated until the old Frenchman pointed it out to me, and he's like, oh, you have sleep apnea because you have a tongue tie. And I was like, wait, what? So tongue tie is just literally where you have this tether at the bottom of your tongue, and it just it's a tissue that holds your tongue down. So you should be able to, if your mouth is totally open, take your tongue and touch the roof of your mouth with the tip of your tongue. Yeah, I totally can't. I'm like that. So what happens is then, so instead of my tongue sitting in, I were talking about in the palate, what it does, it would push forward to my teeth. We talked about pressure, right, and how your teeth are susceptible to it. So I developed this open bite. So what myofunctional therapy is, it's really just therapy for your tongue, to teach your tongue how to have the right tone. So it says there's like a video, and I probably should have included the link here if you guys are curious. But there, the bottom left-hand corner is an orthodontist in the Bay Area actually put these videos together of these different exercises. You could get a therapist who you go through every week. And this is supposed to be an example of a woman who actually underwent myofunctional therapy. You can see just how she had a slightly open mouth, and just you can see the difference of just learning how to keep her tongue in the right posture, how it even just changes her appearance a bit. It's actually quite remarkable. It's side effect free. It's just making your tongue stronger. And they actually even did a study, or they did a systematic review where they found that it actually helps treat sleep apnea. So in children, it actually decreased, the AHI is kind of the severity of your sleep apnea. So for meaning how many times an hour do you have some sort of breathing event or respiratory event. For kids, ideally we want them to have less than 1 an hour. For adults, less than 5. And so all these people, why 5?
10 minutes.
Yeah, no, you're right, yeah. I think part of it is like, it's not every breathing event necessarily makes you wake up all the way. Some breathing events may have you like a little dip in oxygen. It's not necessarily, you can have like a few breathing events through the night or a few times you wake up and still not be. I think the reason why that threshold is made is just so not everybody necessarily has to have a CPAP.
Okay. What exactly do you mean by event?
So an event can be where your oxygen drops by at least 3 to 4%, but that can be from 99 to 94. So it's not necessarily it's dropping low. It can mean that we're kind of struggling to breathe and you actually gasp awake. An event can also mean where you actually just have what's called essential apnea, or just a pause in breathing, where you actually just don't breathe for a moment. And believe it or not, that's actually, some of it's a little bit normal. So if you think about we could actually all give ourselves essential apnea right now by hyperventilating. So if you try to hyperventilate and you breathe out too much carbon dioxide, your brain will sense that and say, whoa, slow the brakes. Let's hold in some carbon dioxide and take a pause. That's why back in the day, like people when they're having panic attacks, they breathe into paper bags to keep from passing out. It's so they actually don't breathe out all their CO2. They actually rebreathe some of their CO2. Fun fact.
Sorry.
No.
Why do you need some CO2?
So you need some carbon dioxide. That's a good question. Why do you need? That's a really good question. I don't know if I can answer why exactly, but I do know we all have some level of CO2, some level of oxygen. Everything just is in balance. So our body is carbon dioxide signals parts of our brain to tell us when to breathe and when not to breathe. So I think having like a level, not too high, not too low, helps regulate how a lot of our processes work. But why is that exactly CO2? I don't know. But yeah, no, good questions. But myofunctional therapy has been found to actually reduce the severity of sleep apnea by 50% in adults and 62% in children. So just by getting your tongue posture in the right place, you can actually improve your breathing, which is kind of fascinating. It reduces sleepiness, snoring, and improves your oxygen saturation. This is more the extreme option. You can change your bone structure, like we talked about. So kids, like we try to help them grow, but if you're an adult and you're like, I want my bone structure differently, you can do surgery. Again, not always the first option for people, but that is an option. So essentially, this surgery is there's 2 different types of surgery. One is actually breaking the jaw and bringing the lower jaw forward to open up the airway. That's called a maxillomandibular advancement. The other one is actually that palate I was talking about. So if you want to expand it, they can split the palate and kind of put a bar in and open that up that way. Believe it or not, this can be done. The one on the right, can be done in clinic, allegedly. I know. Yeah, like some people have gotten done, then just like go home. I'm like, whoa, okay. The one on the left is obviously more intense. People usually stay overnight in the hospital. You have to have your jaw wired shut for a while.
I had a really big underbite.
Oh, okay.
So the bone and put it up there.
Yeah, so you can probably test. It's intense. It's not a. Yeah, but sometimes
Now I can choose so much more easily.
There you go. Yeah, I always feel like a lot of these things I always tell people, it's like, we're looking at going like, oh my gosh, why would anyone do that? But you're right, it's like, it's balance, right? So I think if it makes your quality of life better, I've seen a lot of patients really benefit from this, but this isn't the first go-to. The first go-to is usually CPAP. And I actually like to say all that stuff too before I tell people. I'm like, or we could do CPAP. They're like, okay, let's do that. I want to do CPAP. So what CPAP is, CPAP stands for continuous positive airway pressure. And then something called bilevel or BiPAP just means biphasic positive airway pressure. So CPAP just means like you have, and the pressure is measured by centimeters of water pressure. It just means it's a certain amount of pressure that's coming into your airway. So you would have I'll have a picture of a mask later, but like a mask that goes over your nose and mouth, and it just pushes air in. And you're like, well, how does that help? What it does, it actually keeps your airway open. So like if your airway is collapsing like this, it just kind of keeps it open. That's essentially what CPAP does. BiPAP, the difference with BiPAP, that helps with that carbon dioxide oxygen exchange a bit better. So what it does is when you take a breath in, it can give you a lot of pressure when you breathe in, like a higher amount. But let's say when you want to breathe out, it's hard to breathe out against a high pressure, so that pressure drops way down, so that when you breathe out, you're not breathing out against so much pressure. So that's essentially what, a lot of people think that bilevel is like a ventilator, like it sucks air in, sucks air out. No, air is still coming to you either way. It's just one really big pressure when you're breathing in, and then a lower pressure when you're breathing out, and it can help with that, and just can help you breathe out more carbon dioxide. If you ever hear the term bilevel ST mode, it just means bilevel with a backup rate. So meaning if you tend to pause or have more what we call those central apneas without an effort, breathing effort, it just will say, oh, okay, hey, we've gone like 10 seconds without a breath. Let's make sure we give you a big old breath. So. The machines nowadays are much better than they used to be. Back then, I used to say bread box, but I realize not people know what bread boxes are anymore because no one has them. But they used to be bulky things with just one set pressure. And a lot of people said they had a hard time tolerating it. How is it since you volunteer your experience? How are you with your CPAP? What are your thoughts about? Did it take a while to get used to it?
Do I do what?
Did it take a while for you to get used to it? Oh, I can.
No, not really. Once I got used to using it, mine I have one that looks like that, and I'm kind of a bottom one, and I'm kind of addicted to it. Like if I take a nap, I'll jerk myself awake, and I hate that. So I use it when I take a nap. I use it when I don't feel well and I'm laying in bed, because it's kind of soothing to me, and I feel like I'm breathing better, and then I sleep better. And I mean, he makes fun of me like I'm a snuffleupagus, but it made a huge difference with my sleep. And I know a lot of people can't get used to it, but for me, the benefits outweighed the bulky thing on my head. So I advocate for them, because if you sleep better, it's going to be better for your body.
Totally. No, it's, I think people at first think that how can I sleep with something on my face, and I'm not going to look sexy. I put this thing, I look like a snuffleupagus. I'm not going to like it. But I will say, and you lovingly tease her, I will always tell people, like, choking your tongue is also not sexy. So I always tell people, like, and honestly, like, joking aside, your partner usually also wants what's best for you. So a lot of people like say, oh, I don't want to CPAP because then did it. But I always tell people, like, very rarely have partners really said, like, oh no, I want you to go back to the snoring, gasping, waking up in the middle of the night. So just a plug there. So the auto PAP now, the new machines now that you're pointing out, I'm glad you got a new one. So these actually auto adjust. So you can actually set, like I was talking about, continuous positive airway pressure. You set one pressure and it just comes. These ones actually will say, okay, let's range between, your doctor will set it, between 5 and 9, and they'll actually will adjust between the pressures based on what you think, what you need. So like, let's say you actually had a really rough day and you're sleeping even really deeply, then maybe it gives you more pressure. Or maybe you don't need it as much, it'll reduce the pressure. And it also has all these different like comfort features, humidification, auto start, auto ramp up. It does all these things. Auto bilevel, same thing, where it can again, within parameter set, it can auto adjust through the night, and again, just really help with your comfort. And they've done studies where they compared the old machine to the new machine, and people say it's a huge difference. And there's a lot of different mask options. So these are just 3. So this is one where you have the nasal pillows just go into your nose. You can have ones that go above your nose. And then I show this one on the right. So some patients who actually need, for instance, bilevel support for prolonged periods of the day. The nice thing about that one, it goes under your nose, so you can still wear your glasses with it. So the other ones you can see, those are harder to do. So these are really helpful a lot. Some of my patients also have like neuromuscular weakness, and so they're like on BiPAP for like 20 hours a day. So it's having a mask that they can actually still like function, go to school with, those kinds of things.
I have the middle one.
The middle one?
He used to use the nose ones. I
Mm-hmm.
don't like them.
I used to have, for the record.
So you were also like a snuffleupagus.
I was. I looked just like that on the left.
And the nasal pills, a lot of people go to those ones because it's smaller. But I will say, because it kind of sometimes can put pressure on your nose, sometimes the bigger masks are actually more comfortable. So if your doctor recommends a big mask, don't completely get mad at them.
Well, wait, question for you. Though.
Yes.
Why didn't you think these were sexy? Because
Is that doing it for you?
like this guy on the right.
Yeah.
I mean,
There you go. Okay, well.
Maybe you just need a different color.
Yeah.
Maybe.
They're actually not that uncomfortable, and they have magnets on them now, and
Wow.
yeah, you don't have to worry,
I love it.
Especially when you disconnect and walk around like that.
Like what?
You don't take the whole thing off, you just.
You just disconnect that and you're like, sup. I love it. I love it. It's
Like
mo-
a fighter pilot /
Yeah.
Darth Vader. kind of-
Yeah. So the ones for kids, is actually we put some kids in these. It's like a giraffe print. They put all these different prints on it, different colors. So yeah, we try to make it fun. But the sexy part, that's new for me. Okay, I'll try to see if I can use that as part of the appeal. Going slightly different, insomnia. So this is just often inadequately discussed and often underdiagnosed because I think a lot of people just assume oh well, whatever, I just can't sleep well, I have to deal with it. And so a lot of people will self-treat with alcohol, meds. I always tell the story about this lovely 83-year-old woman who came to see me. She was having insomnia. She would take a shot of whiskey before bed every night. And the problem with alcohol is that, sure, it knocks you out, but then it was one of my attendings used to always say, it's a short-acting drug. After 4 hours, it wears off, right? And then you wake up. It metabolizes into sugar, and you're awake. So I say, well, what do you do when you wake up? She's like, exactly. She's like, I take another shot. And I was like, okay. But she's 83. She's not doing anything. She's like, whatever. So, but I think taking a shot of whiskey at 4 a.m. is probably less. I'm sorry?
IV drip. That's the
That. I know. Done. IV drip of whiskey. So yeah, maybe not the best. And then oftentimes when people bring it up, a lot of doctors might just say, okay, here's an Ambien, and off you go, without really a lot of counseling. And the problem with Ambien, Lunesta, Sonata, all these hypnotic meds, yes, they will work initially. They will make you fall asleep. But if you think about it, your brain is actually designed to combat whatever's hitting it. So what those drugs do, in a very simplified way, is they actually will hit a receptor and slow your brain down. And so the first couple times your brain will let that happen, okay, it's hitting me down. But then after a few days, they'll say, wait, I'm going to get around this Ambien. I'm going to make more receptors. And then when you take the same dose, you're like, the dose doesn't work as well as it used to. And so then you find yourself having to increase the dose. And then over time, your brain's like, you're increasing it? I'm going to make more receptors. And so you can see how they don't work. So they all are designed. I'm sorry?
and then you cook something while you're sleeping and you burn down your house.
It's true. The side effects can be kind of crazy. So people have been known to sleep drive, sleepwalk. I had a patient who walked out in her underwear in her neighborhood. Luckily, she had a neighbor look out for her. People can do crazy things. They're called hypnotics. So, yes.
Someone I knew in college was on Ambien, and while he was in some sort of dream, he ordered shirts for everyone in this club. They turned out great, but it was really weird.
Yeah, people have driven and come back safely, but don't remember it at all. So you can do things, but it's scary. Oh, he remembered. Oh, interesting.
Yeah.
I don't know if he remembered
He
it.
was, not yet asleep and just ordered
Got it.
this design that was really gay.
Interesting.
Yeah.
So, so I think there's potential side effects doing things that you don't fully remember, that you're not really planning on. So that's why I actually haven't really ever initiated anyone, even though I'm a sleep doctor, on any hypnotic. There are a lot of patients who come to me who are already on it, but it's actually in the sleep medicine world, not the first line. Oh, yes.
My doctor actually prescribed trazodone. Is that in the same? That's not a hypnotic though.
Say that. Mine too. It's stuff.
Yeah, so it's antidepressant, so it's a little bit different, and it works a little bit differently. So it's not quite as And it's like dependent inducing. Not that people are like, craving it, but like it doesn't have the same quite effects. And I think it's really effective for people who have some insomnia, PTSD, some depression. So it's helpful in those ways. So trazone's a little bit different.
I take
What's the brand name of
milligrams of
trazodone?
trazodone, and that knocks me out. It does a good job.
Trazodone is the brand name.
I don't remember the chemical name.
That was the one from Valley of the Dolls, right?
I've never seen that movie. I don't know.
Well, it's a book too. She took dolls, they're barbiturates.
Oh, well, trazone's not a barbiturate, but
Sorry.
oh no, sorry, not a barbiturate. It's classified as an antidepressant.
Oh, got it.
Just curious what your opinion is about just plain old Benadryl.
Oh, great. Oh, I don't think I put a slide. Thank you for asking that. So Benadryl, it is an antihistamine, so it makes you sleepy. There's a couple issues with Benadryl. It's okay I think for short term, right? If you especially have allergies but long term, it can actually cause side effects like urinary retention. And I've seen it. It's a big deal. It's not pleasant. It decreases your respiratory drive. So it kind of sedates you a little bit. So I think Benadryl is not a good long-term solution.
Your body adjusts to it. You need more and more over time.
Sure, yeah. So Benadryl, your body definitely can, adjust. I had a patient who was taking 250 milligrams of Benadryl a night. I mean, this poor dear, she was just really just needing more. And this is, developed over time, over months. But another one, Unisom. I'm forgetting the drug name in it, but the Unisom, another over-the-counter one, is actually has more risk of developing dependence than even Benadryl does, which is interesting. You can have more rebound insomnia. So those things are not, again, acutely short term, these things are okay. Your jet lag is, you have a big presentation tomorrow, whatever. I think it's okay for the here and there, but I think people are often treating a chronic problem with things that aren't meant to be chronically used. But thank you for asking Benadryl. Yeah, it's very commonly used. The gold standard now that we're finding in sleep medicine is actually something called cognitive behavioral therapy for insomnia. I know a lot of people have heard of cognitive behavioral therapy, but this is different. This is very specific to insomnia. So one of the behavioral therapy, she always says, we don't have time to talk about your mama. That's not what this is about. This is very specific about the things that you do that seem intuitive at first, but actually are making your insomnia worse. So there's a little bit, so it involves a couple things, right? So first there's just the sleep hygiene tips that you start with. So the things that I always tell people, for one, make your bed your sanctuary. So the rule is really your bed should only be used for two things, one which is sleep. It's funny, in the pediatric world I can only say one thing. So no work, no emails, don't fight in bed, don't watch movies in bed. So if you're and granted, some people are like, I do it and I sleep fine, then you don't have a problem. But if you actually are having insomnia, really start to kind of make your bed your sanctuary. Incorporate a wind down routine. When we're kids, it's so funny. We have this routine, our moms read to us, or they read a book, and then when we're adults, we're like, we don't need that. Not true. Our brains need the exact same wind down. So 60 minutes before the start of bed, I say dim the lights, start to just kind of calm down. Don't start that discussion about finances with your partner at right before you're going to go to bed. Yeah?
For avoiding screens, how do you feel about blue light filters?
So the question was about blue light blockers. I'm for them. I don't know if they fully block all the light, but it's better than nothing. So I think if you have to be on your computer, have to be on your screen, it's not just I just really want to watch YouTube videos in bed. But if it's I have homework or I have work to do, then I think it's better than nothing. And I actually on my, because I'm well in the Apple universe, I have a MacBook Air and a phone and tablet. So actually at 9 p.m., the nighttime, that reduces the amount of blue light. I see a lot of people nodding. So I do that every time at 9 p.m. That tells me, okay, it's now, let's start to, reduce our time. Sometimes I have to stay up and I say, no, I must. Give me the blue light. I have a lot of work to do. But the better is to decrease that. And you can buy the glasses. Back in the 80s are these blue blockers. Yeah, I remember, yeah. Right on. Talk about sexy.
Yeah, wear that plus the CPAP.
I mean, yeah, there you go.
This big old orange, like those old people those glasses they shove the little slits in them.
And it's orange and and with the CPAP unhooked, yeah. So they now have blue blocker glasses that are a lot more subtle. So you can actually get blue blocker glasses that look just like regular glasses that may have like a slight yellow tint to it.
I
So,
think you need to have on the sides too, don't you?
well, I mean, ideally.
That's what those blockers
I mean, yeah, those ones are like the real deal. They'll block everything. But if you're trying to like not look like that, you can, you know. I always tell people it's like everything. It's, you know, give and take. Don't watch the clock at night. So one of the things that people who have insomnia do, maybe you guys have done this, like, oh, I have 7 hours of sleep. Okay. Oh man, now I have 6 hours of sleep. Oh, now I have 4 hours of sleep.
That happens every night.
Yeah, and you feel like you're like, oh, well, I need to know how many more hours of sleep I have because something bad will happen. Like, we actually, it's so intuitive to watch the clock, but actually, has it ever helped you calm down and feel better? No, it revs you up, makes you more nervous. So that's actually one of the key things too, is like, don't look at the clock. Ideally, like if you can have if it's your phone or a clock, like actually set the alarm and just put it aside and know if the alarm's not on, it's not the time I need to wake up yet. So don't even look and see. And that's hard to do. I do it all the time too, and I know like this is bad. I should stop. And the other thing is actually remaining in bed awake. So going back up to why your bed should be your sanctuary is so if you're even trying to do relaxing activities in bed, your brain is trying to figure out, what do I do in bed? Do I read email? Do I watch movies? Or do I sleep? I'm not really sure. We do all of them. So if you're not sleepy, actually reduce your amount of time in bed awake. So actually get out of your bed. And then ideally, you know, if you have a chair in your room or you can do something relaxing, a lot of people go, especially my teenagers, well, what am I supposed to do if I can't look at my screen? And I'm like, oh my God, what do people do before tablets? I always say you can read a book, do a puzzle, fold laundry, pack your lunch for the next day, just do something that's kind of boring, but is not a screen and just kind of helps you kind of relax for the night. And then when you start to feel sleepy again, try it again, go back into your bed. And what do you say? Well, now I'm awake. What if I go back to my bed and I still can't sleep? Do it again. Get out of your bed. Do something else. And I know for the first couple nights, you're going to be annoyed with this. But the hope is by the next night, back when you actually get into bed, it'll be much faster. You're actually going to fall asleep. You're going to have built up your sleep drive, or it actually becomes easier. But you really are trying to re-establish your association with your bed as a place you sleep, not a place that you think, not a place that you fight, not a place that you do homework. So, and then keeping the same sleep time schedule each day. Your brain really, again, doesn't do well with switching back like, oh, Monday through Friday, I wake up at this time, and Saturday, I wake up at noon, and then Monday, I go back to 6 a.m., and that doesn't really work. We need a pattern. So I think trying to, varying within like an hour or so is fine, but trying to keep the same schedule is also important. And within 15 minutes of getting up, trying to get some bright light. So especially in the summertime, this is more doable. So try to go onto a patio, open a window, actually get some bright light. And then I was guilty of this morning. Don't snooze. Don't hit the snooze button. It's tempting, but it actually, if you think about it, it actually only makes it worse. How many of you ever feel better from snoozing? Oh, okay. A couple people. I've never, I just get to the point where I'm like, I have to get up or I'm going to be late to work. So I don't feel like I ever feel like, oh, I feel so much better. In fact, I usually get a headache because I usually wake up in the middle of a dream, and I don't like that.
But isn't there like a process of waking up where you're sort of like for me, I need to wake up over some minutes,
Yeah, like a gradual.
I can't move when the alarm first rings.
Oh, yeah, that's fine. Yeah. So you have 15 minutes to just kind of think about it. And 15 minutes. Yeah, I'm not saying you have to jump out of bed, but just the trick is don't go back to sleep. What I do, I typically turn it off and roll over.
I guess that's where the snooze button actually helps me because, if I were to just get up when the alarm goes off, that would suck. But it goes off 9 minutes later, and I'm like, okay, I can start moving. And also, sometimes if I turn the alarm off, I will fall back asleep forever.
Yeah, I mean, that's a tricky thing. So I think ideally, if you can turn the alarm off and then just kind of lay in bed and you can think and kind of prepare for the day and then get up is great. But I think a lot of us, we just fall back asleep. And then you get in that spiral of snooze. Okay, just 5 more minutes. Okay, 5 more minutes. Okay, 5 more minutes. And then, oh my gosh, I'm late. So I think that's ideally trying to avoid that as possible. But these are all tips, and you might find that you actually need something a little bit different. And the most important part about these are really if you're having insomnia and really having a hard time. If you're no, I'm good, this works for me, then it's fine. So real quick thing about Supplements, I'm not going to touch on all of them because as you can see, if you walk in through a vitamin aisle, I mean, it's like everything is for sleep. So really quick about melatonin, because I think that's the most common one people talk about. So for general insomnia, 1 to 3 milligrams, like 60 minutes before bed, is how you can use it similar to a hypnotic way. Let me take a step back. Melatonin is a hormone that's actually made in your pineal gland in your brain. So it's actually a natural hormone you already make. And so what people are trying to do is like, well, let's get melatonin and give it to you and have that same effect. That's the hope. I will say a lot of studies have shown that actually a lot of things that say that they have melatonin and don't have the exact amount. A lot of these supplements aren't necessarily regulated, so it's sometimes tricky just to be aware that not everything this says 3 milligrams of melatonin. They did a study where I think they looked at 20 different brands, and I think something like, I can't remember exactly, 18 out of 20 of them had like just doses that were all over the place. So just to keep that in mind if you're taking a supplement. But if you want to aim for 1 to 3 milligrams 60 minutes before bedtime to help you fall asleep. More is not more. So you can buy 10 milligram tablets, but you don't need 10 milligrams. So what actually ends up happening is maybe you fall asleep, but then you're actually still groggy the next day because it's still in your system. So I really tell people if you go to 3 and it's not really working, I don't generally say to go up. Granted, someone's already like, I'm already on 5 and my life is great. I'm like, okay, I'm not gonna mess with it, but I generally don't go up. Because really, if you think you're a physiologic dose of what you have in your brain already, or like what your body naturally makes, it's like 0.5 milligrams.
Is this synthetic usually, or is it animal derived?
Oh, that's a great question. You can get synthetic or animal derived. I think generally in the store, the vast majority is synthetic, and that's thought to be somewhat safer, I think, than the bovine derived one. I think you have to seek out the bovine derived one, like if you really want a quote unquote natural one. And I think it's thought to be safer because it's like an animal product that's not really well regulated. So I think people tend to worry about that one. Short term, we feel like it's safe. Long term, no one knows, to be blunt. It's like it just hasn't been studied. So those 20-year studies of melatonin, it's a hard thing to study because it's just all over the place. So people just don't really know. So I say it's a good tool to use, but it's not something that I think everyone needs to be on if they're having trouble. I think it's all these different behavioral things that have been found to be more effective. In children who have like neurologic abnormalities, like they tend to have seizures or developmental delay, they actually tend to have a relative melatonin deficiency. So those kids actually do keep on the long term, but that's a specific population. And then the last thing I'll say about melatonin is delayed sleep phase syndrome. So this is that natural thing where you become more of a night owl. So all teenagers naturally become night owls. It's not their fault. But unfortunately, they still have to get up early to go to school. So if you have this, actually taking a really small dose, 0.3 milligrams, 5 to 6 hours before you want to go to bed, actually helps shift that circadian rhythm. It's not like forever, but you do this for like a couple of weeks as you're also trying to do all those other sleep hygiene techniques. That actually helps shift your circadian rhythm, your natural rhythm, that you actually want to wake up earlier than you normally would before. So during my fellowship, I had a lot of software engineers who are night owls. And so they would go to bed at 2 a.m., wake up at noon, and their life was good. They got promoted, and now they have to go to meetings at 7 a.m. They're like, whoa, I can't do this. So those are people that we would shift the circadian rhythm. Some potential side effects. Some people get nightmares from it. The daytime sleepiness we talked about, I think are the most common ones. Yes?
So besides this, I'm just curious what your explanation is for nightmares.
Oh, why melatonin causes nightmares, or?
Aside from why melatonin.
Oh, why nightmares?
Yeah.
That's a great question. I don't know. I don't like what. So I know that like if you are having sleep disturbances, you can have more nightmares. So like people have sleep apnea tend to have more nightmares. And thought is that it's like your neurologic response to like feeling like you're suffocating or that you're under stress. But you're asking like the big question, like why nightmares? I don't know. That's a great question. I wish I knew. Other natural remedies to consider, I mean, there's a million, but I just mentioned some that seem to be the safest. Valerian root may relieve some anxiety, chamomile, and lavender, I think, are some of the ones. And I think it's just really important, if you want to try any of these natural remedies, just double check with your doctor, make sure none of these like interact with your other medications, because some of these things can actually, a really important place to go back. Melatonin, there's a question of whether or not melatonin can actually affect anti-rejection drugs or immune suppression. It's funny, I've been trying to really look through the literature, and there's some that say, oh, it makes them more effective, and other ones that say makes it less effective. So I feel like the people are still unsure of what melatonin does specifically with your anti-rejection medications. If I have a patient who's already on it, I'm sorry?
It might be like one medication it does something, but not another medication.
Exactly, yeah. So it might just be, I think it's harder to study. So I think they're looking at specific Progress, sirolimus. I think it could also be like, how do you know what's like really in the melatonin isn't? So I think it's a complicated question. But that's the only thing I feel like if I have a patient who's like a lung transplant patient, I always say, well, let's just be careful. Let's try with a low dose and let's not, get too funky with it. Sorry, you had a question.
So, what about drugs like Xanax or Klonopin or Valium, or I don't know what they're classified as?
Yeah, so like benzodiazepines, I think is what you mentioned. I did not even bring them here. I typically don't, well, granted, I'm a pediatric practice, so I think especially I try to avoid those just because with kids in general. I think in terms of pulmonologists, I think we try to reduce using those because it reduces your breathing drive. So that's the biggest fear, is if you kind of take too much Xanax, it actually reduces your drive to breathe at night.
That's why I had asked about the comparison between
Yeah.
breathing at night with those versus without them, specifically for CF.
Yeah, I got to look back. I don't remember seeing anything in the literature that compared that, but I do know comparing people who were on them, like just in the general population, not necessarily picking people specifically with CF. I know that we do know that it reduces your drive to breathe. You can be easily dependent on it. So I think it's, again, one of those things where maybe acutely for like anxiety, it's helpful, but if it's insomnia's issue, it's not something that typically should be prescribed for insomnia. But it often is. Yeah. So when I have patients who are on like Xanax or Ativan to help them sleep, I always try to do other things to see if we can kind of wean them off of it. But that plan is very individualized. Good question. Yeah, sorry, I guess I didn't fully answer your question then that you had earlier. Sorry. But ask your adult lung doctors, because I think they might have just more experience with more patients on it than I would. Yeah.
Have you experienced people who are addicted to Ambien?
Yeah. Yeah.
Is there a way to get off that?
Yes. Cognitive behavioral therapy for insomnia, believe it or not. So I had a patient who had been using it. Oh, sorry, his question was, can people be addicted to an Ambien? Granted, it's not that they're jonesing for it in the same way, but it's just like they can't sleep without it. So we do know that happens. And so cognitive behavioral therapy for insomnia can get people off of it. It's gradual. You never want to do it just cold turkey without any tools. But I had a patient who was on it for 30 years and was able to get off of it. Yep.
I take trazodone at night because Ambien didn't do anything for me. What exactly kind of drug is that?
It's good. So it's classified as an antidepressant, and for some reason it seems to be better long term. People develop less dependence on it. I don't know. A lot of these meds, quite frankly, people are still trying to really figure these out. So I know like people like doctors prescribe it like, oh, you need this. They only like half understand them, to be really blunt. But I think trazodone is thought to be pretty safe to use long term. So I know it's used a lot, but it's classified as an antidepressant medication.
I have heard that your body knows whether it's morning or evening when you take trazodone, because if you're using it as an antidepressant, it won't knock you out during the day, but it will at night.
Yeah, that's the thought. Yeah, that it actually, some people can take it during the day and feel drowsy. So I've had some patients still feel kind of groggy when they take it in the morning. But I think that's the thought. That's how people usually use it. Like daytime, higher dosing, used as an antidepressant, and then like lower dosing used to help you sleep, which is interesting.
When I was in the hospital recently, they switched me from Remeron to trazodone because because of sleep issues, and I was taking such a small dose of Remeron these days anyways, that the antidepressant effect, I guess, wasn't really that much of a thing, and I've been taking Remeron for years at night, partly with the intended effect of having it make me drowsy, but also stimulate appetite. And so then I developed a habit of just scarfing down food right before I went to sleep.
It's a common side effect
yeah.
with it. Yeah.
And my sleep habits and feeling groggy the next day and all that like hadn't really changed for a while. So we tried switching it up. But what I was told was that trazodone is good because like it was intended to be an antidepressant, but apparently it sort of sucks as an antidepressant.
Correct.
But what they did find is it makes people sleep. So and so far it seems better.
Great. Yeah, it's a lot of this when it comes to pharmacology of insomnia and all these things. It's so individualized, right? I think if you're doing something and it's not really helping you, I think talking to your doctor about changing things up, because there's a lot of different options out there. Sometimes it's combination, sometimes it's totally switching out. It's just so I'm glad that you just said, hey, this isn't quite working. Can we try something different? So I would say that's if that's the only message I can say about the different pharmacology for insomnia is just not one recipe is going to work with everybody. But I think being willing to keep trying to feel better, I think is important. But taking into account some of these behavioral things too, on top of it. Not that you have to can't take medications, but you'd be surprised how they did a head-to-head study with Ambien and cognitive behavioral therapy for insomnia, and they were just as effective. The one thing is that the CBTI actually had better long-term data, past 6 months. So even though I know it sounds like it's oh, just get me off my phone, and a lot of people when I tell them, especially teenagers, roll their eyes so hard every time I tell them what to try. But if they actually kind of try the program, they're like, oh, I do feel better. This kind of works. So I think it's a combination of the two. Yeah.
Does lavender really work?
I know, it's crazy. Yeah. It was, what was it? It was German lavender, something specific. And I think they tested in oil and tea and yeah, it really works.
My mom is always trying to give me that stuff, and I'm like, okay, I'll try it.
Yes, a lot of them are combined. Yeah, and the thing I like about these is these are generally pretty safe. If you're not going crazy with the doses, they have low side effect profile, don't tend to interact with medications.
What even is valerian root? Because the name of firms is valerian steel, which is one of the things you could use to kill night walkers. So
Did you have a question?
Yeah, it's an herb.
so that's where the steel comes from.
That on its own can make you a little drowsy the next day. You might want to
They sprinkle valerian root into the steel.
That's what they use for the carbon to bring it in.
It makes it hold together,
Yeah.
I'm changing the subject.
Game of Thrones, yes. So it's
Very,
2:30.
and very different question about why my husband puffs when
Oh.
he sleeps, and I'm wondering why does that happen?
Like-
And all night long. What does that do? Is it like
My
a
only thought is,
COT?
again, is it positional? Does he do it more when he's on his back?
I don't know.
Is he smoking at the time?
He's blind smoke rings.
No, I think he's on his side.
A lot about blowing out candles.
It's
He's on his
probably,
side.
he might have some nasal congestion. He's just trying to, it's like a pop off, right? So that's my first thought. And it'd be interesting to see if it is worse when he's on his back. 'Cause usually
Okay.
breathing
I
is a
wasn't
bit
sure
worse.
if there was some sort of physiological purpose for it.
Oh, I can't think of one.
Okay, that's good.
All right. Sorry, I know. And I'm going to just mention a couple other things, but I know it's 2:30, so I want you guys to get to your, medieval field game, right? What was it? Yeah, I don't want to get in the way of that.
It's at 3,
But you guys need,
half-hour break.
Yeah, I'm gonna.
We want to respect your time, too.
Yeah. Okay.
You should join us.
Yeah,
I am tempted. I have a meeting at 3, but I wish I'd known about medieval games. I would have.
Well, if you brought your sleep meds, you would have an advantage because you'd knock everyone out.
That's true. I would just blow valerian root on everybody and then.
Valerian, nice.
I know. Yeah, see, I was paying attention. I've never seen Game of Thrones, but I still could stay. I could fake it. Real quick about periodic limb movement. So this is something where it's like jerking of your legs or your arms. Usually the partner is annoyed by it rather than sometimes you can wake from it. This is different than something called restless leg syndrome, which is this feeling or this need to move your legs. I'm seeing some people nodding that they experience it. It actually can be quite miserable. There actually was a case report of a woman who had CF and she had chronic hemoptysis and was actually found to have some restless leg symptoms. The restless leg and periodic limb movements are often associated with the low iron levels. It's interesting because they used to measure iron levels within your central nervous system, so in your cerebral spinal fluid. Back in the day, they used to just like do a spinal tap to check this. We don't do that now. Instead, we check a ferritin, which is thought to be a surrogate of the iron stores. So if you're having symptoms, mention to your doctor because it can be miserable. It's a big deal. And sometimes, hopefully, iron actually can... getting iron supplementation can actually make those better. Granted, of course, there's always a balance. There's a lot of discussion about iron with cystic fibrosis, and if you're actually having an exacerbation, should you iron? So I mean, it's a discussion of whether or not because iron is thought to sometimes feed bacteria, so to speak. So it's a little bit of a discussion. But I think if you're really having symptoms of restless leg, and you're really uncomfortable, or you keep kicking your partner and don't know why, it might be worth checking.
Divorce.
Or just divorce. No, I'm kidding. No, check your iron. So no, go ahead.
Sorry.
No, please.
I have GERD, so I'm up on like
Oh,
pillows. And I'm just curious if you've had any experience with just that itself messing sleep up.
Totally,
Sitting
yeah.
up and then back pain because of that.
Yeah.
Sleeping on your side on an angle.
Yeah.
Any ideas or thoughts or suggestions for that?
I mean, trying to reduce the acid in your stomach, with an antacid, it doesn't stop the reflux, but actually makes it less painful when it does reflux. So that's one thing. These new beds, and not that I'm saying go buy some like fancy, expensive bed, but where they can kind of like recline up. That's some patients have found that to be helpful. Sleeping on a wedge has been kind of helpful. A little bit less pressure on your hips. But that's a tough problem, for sure. And yeah, if you're having reflux in the middle of the night, that'll wake you up. So this is just saying, I think we've already talked about this, this is just when to get a sleep study. So if you feel like you're sleepy, you're tired, you have any concerns whatsoever. Also, if your FEV1 tends to be less than 65%, the literature seems to show that tends to suggest that you could have these issues with carbon dioxide and oxygen and all that. So I think have a low threshold to get a sleep study just to help your health. And then some take-home points, which, like I said, I can just email to you guys, and then I'll give you my contact information too. But you don't have to ask me more questions. I know you've had them out. But I want you guys to get to your medieval games because now we're 3 minutes after. Thank you.